Hello, good morning everybody. Welcome to this series of Histro Tips. So together we will discuss some of the practical issues that you face during operative hysteroscopy, and sometimes you get confused and maybe the answer is not in the textbooks, right? I love very much the statement that those who learn surgery from textbook should operate only on the textbook. Textbook give you science, but the real skills and the experience when you inside the operating room. So let's talk about bleeding in hysteroscopy. To start with, and I'm sure not everybody agree with me, even my beloved son who is smiling now, when I say that there is nothing called bleeding in hysteroscopic surgery. It never exists. But sometimes after finishing a myoma resection or a septum surgery or anything, and then you finish, the nurse call you back that, sir, there is some excessive bleeding. What should you worry about and what should you do? First thing, put a vaginal speculum and check the cervix before worrying about something inside the uterine cavity. Many instances, when you grab the cervix by a tenaculum and you dilate or you're doing resectoscopy, sometimes the tenaculum cuts into the cervix, and this is the source of the bleeding. So if you don't take care about this and you go directly to check the cavity inside, you will miss the diagnosis. So check the cervix for any bleeding points. Then raise your eyes and look at the monitor, check the blood pressure and the pulse, so you can evaluate how much blood loss happen and how much this affect the status of the patient. Another thing, go inside the uterine cavity. If there is a bleeding, the cavity will be full of blood clots and you will not be able to see well, and you will not be able to reach the source of the bleeding. So what to do? Here you have to play very well with the inflow, outflow. There are two channels, the inflow and the outflow. And please, some of what I say is not standard. Many people do not agree upon. I am totally against using suction in hysteroscopy. There's nothing called suction. Suction will collapse the cavity and it will collapse over the blood clots. On the contrary, you need to have the cavity distended and then push much fluid and open the outflow in and out, in and out. It's not continuously out. You have to master this. It's not just a matter in and out. So the inflow, the water will hit into the fundus, will make a turbulence, push the clots back, then open the outflow, and this will clean. And one more thing, sometimes a big clot will not go out by the outflow. No, it will stay inside, keep rotating inside, and then you cannot see anything. So what you do, pull the telescope, you love this trick, Yahya. Pull the telescope a little bit out and open the outflow, so this will create some suction pressure, and the clot will be dragged until you reach near the external os, and the clot will fall out. Sometimes even you don't pull all the way out, still you're inside the cervix, but the clot will escape from inside. So just gentle, judicious in and out, in and out. This will make all the clots to be pushed outside. And give it time. It's not like laparoscopic surgery. In laparoscopic surgery, you can irrigate and quickly you suck and you have the good view. But in hysteroscopy, you get frustrated. And many of my students, they get frustrated. No, we cannot clean the cavity. Just give it time. Time doesn't mean 1 hour. It's 2 to 3 minutes with the judicious use of inflow and outflow. Then when the cavity is distended well, check if there is any bleeding point. What happens if you see a pumping bleeder? Will you go and cauterize? In my opinion, no. You don't need. You don't need at all. Actually, any bleeding coming from the surface of the endometrium, where it comes from, remember the anatomy. You have the uterine artery, and then the arcuate artery, the radial, and the spiral. So they come to the cavity through the myometrium. So if there is a good myometrial contractility, it will stop any bleeding, unless one case, I ignored the bleeding and it continued very heroic, because the patient was severely hypertensive. So check the blood pressure. If the blood pressure is very high, you should not leave the patient until it's controlled, because the high blood pressure will keep pumping into the vessels and it will never control the bleeding. So once upon a time, I saw Yahya doing a septum, and then he saw some bleeding points when he was starting. He said, Dad, should I cauterize this? And he could cauterize and maintain hemostasis, but in my opinion, it does not deserve. Just give it a time. Sometimes there is soft uterus, not contractile, so you manage the same like postpartum hemorrhage, just by manual compression. Tranexamic acid, intravenous tranexamic acid, by manual compression, and wait 8 minutes. Believe me, I reassure you, if you remove your hands, absolute hemostasis. So never panic from uterine bleeding. What else he wants me to tell? He is waving to me, you have to speak about that and that. Okay, so check the cervix, irrigate the cavity well. Should we put a balloon inside the uterus? It's absolutely wrong, in my opinion, because if you put the balloon and distend the uterus, you will interfere with the myometrial contractility, and you cannot guarantee that the balloon will compress the bleeder. Probably the balloon may compress one side of the uterus and the bleeder will be still pumping. On the contrary, if you deflate the uterus and contract, this will squeeze the blood vessels. Depend on the living ligatures, the myometrium. So putting a balloon is not a solution. Tranexamic acid, by manual compression, wait for 8 minutes, 100% the bleeding will stop. And don't forget about the cervix. And stay tuned, much more is coming. They are calling me now for the next case. In between cases, I will invest my time to give you all the history tips. Thank you, good luck, bye-bye.